Ketamine infusions for chronic pain are everywhere now. Cash pay clinics, mobile services, telehealth referrals. But what do the three largest pain medicine societies in the United States actually say about which patients should get them? In 2018, they spelled it out. Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the research that shapes how pain medicine is actually practiced. Today, we're presenting the 2018 Consensus Guidelines on Intravenous Ketamine Infusions for Chronic Pain, a joint document from three societies: the American Society of Regional Anesthesia and Pain Medicine, the American Academy of Pain Medicine, and the American Society of Anesthesiologists. Ketamine has been clinically available for almost 5 decades. The dramatic expansion of its off-label use for chronic pain prompted these societies to publish, for the first time, comprehensive guidance on when it's appropriate, how to dose it, and what to monitor. The guideline isn't a trial. It's a consensus document. A panel of physician experts reviewed the evidence for ketamine infusions across multiple chronic pain conditions, graded that evidence, and translated it into practical recommendations. It covers indications, contraindications, pre-procedure testing, infusion monitoring, dosing, what counts as a positive treatment response, side effect management, and the role of oral and intranasal ketamine after an infusion course. Here's the important framing. A consensus guideline can rate the evidence for using ketamine in one condition as moderate and the evidence in another condition as weak or no evidence. Both ratings appear in the same document. Both are honest summaries of what the published literature shows, but they mean very different things in practice. Moderate evidence means meaningful randomized trial data supports a benefit, even if confidence intervals are wide. Weak evidence means small studies, methodological concerns, or mixed signal. No evidence means the trials needed to answer the questions simply haven't been done, or the ones that exist don't support a meaningful effect. When ketamine is being marketed to a patient for a specific condition, the question that matters is, which of these categories does that condition fall into? The guidelines reviewed evidence across 7 chronic pain conditions. The results are uneven. Moderate evidence: ketamine may provide improvement up to 12 weeks, supports use in only one condition: complex regional pain syndrome, or CRPS. Weak evidence: short-term improvement only, supports use in spinal cord injury pain. Weak or no evidence for immediate improvement was found in mixed neuropathic pain, fibromyalgia, cancer pain, ischemic pain, headache, and spinal pain. That last list is worth pausing on. Mixed neuropathic pain, fibromyalgia, cancer pain, ischemic pain, headache, spinal pain. These are conditions for which ketamine infusion is increasingly offered. The 2018 Consensus document, written by physicians from the 3 major U.S. pain medicine societies, concluded the evidence supporting these uses is weak or limited. That doesn't mean ketamine cannot help these patients. It means the trials needed to demonstrate that it does help, at scale, have not been completed. The guidelines provided specific dosing. Bolus doses up to 0.35 milligrams per kilogram. Infusions ranging from 0.5 to 2 milligrams per kilogram per hour. A total dose of at least 80 milligrams infused over more than 2 hours, with the evidence suggesting higher doses over longer time periods and more frequent sessions produce greater benefit. Contraindications are explicit: pregnancy, active psychosis, poorly controlled cardiovascular disease, severe hepatic disease, elevated intracranial or intraocular pressure, active substance abuse. Monitoring requirements depend on dose and patient risk. No testing is required for healthy patients at standard doses. Patients with cardiovascular risk should have a baseline echocardiogram. Patients with liver dysfunction or expected high-dose courses should have liver function testing. The personnel requirements are striking. The supervising clinician must have substantial clinical experience with ketamine, be ACLS certified, and be qualified to provide moderate sedation, typically an anesthesiologist, critical care physician, emergency medicine doctor, or pain management physician. The administering nurse or PA must have formal training in moderate sedation. For higher dose infusions, a monitored setting with resuscitative equipment is required. That last detail matters. Ketamine infusions are delivered in a variety of clinical environments, and the guideline lays out the minimum standard any setting offering them should meet. So what does this mean in practice? First, for patients considering a ketamine infusion, the most important question is which condition the infusion is being offered for. If it's CRPS, there's at least moderate evidence supporting a defined treatment course. For most other chronic pain conditions, the consensus evidence is weak or absent. That doesn't mean it won't help, but the published support is thinner than the marketing suggests. Second, the personnel and monitoring requirements in the guidelines define the minimum standard. A guideline-consistent ketamine infusion is delivered by clinicians with sedation training and ACLS, in a setting with resuscitation capability. Third, response should be measured. The guidelines recommend objective benchmarks, at least 30% pain relief plus a validated condition-specific measure, to define a positive response. Repeat infusions without measured improvement aren't supported. Bottom line, the 2018 ASRA, AAPM, and ASA consensus guidelines say ketamine has moderate evidence for CRPS, weak evidence for spinal cord injury pain, and weak or no evidence for most other chronic pain conditions, including fibromyalgia, headache, and spinal pain. Safe infusion requires sedation-trained personnel in a monitored setting. If a clinic is offering ketamine for a condition outside the moderate evidence category, ask what response benchmark will be used. A reminder before we wrap, this is educational content, not medical advice. Talk to your own doctor about your specific situation. If you found this useful, hit subscribe. Next week, we're breaking down the MINT trials, the 2017 JAMA paper that questioned whether radiofrequency ablation works for back pain, and the response that followed.